Yes, ma'am. Yeah, hello, good evening. Welcome to yet another podcast from PACESDIARIES.UK. And now we are going to start our podcast, especially on clinical communication, which is one of the notorious stations in MRCP UK PACES examination. And as we did our survey, we surprised to know that a lot of candidates who just flunked in communication skills. There are two stations to trap you out. And now we have a very special guest with us, and who is my mentor and who trained me and who supported me, okay, in every possible way during my PACES journey, and I would not have cracked the exams without her. And I'm very proud and very happy to introduce you Dr. Lavanya, and she has done her MRCP UK PACES examination and MD Internal Medicine from India, and she has practiced in Vinayaka Missions Medical College, and now currently she is practicing in Salem, and she is also running an institute that is, target PACES for MRCP UK. All right, and let's welcome ma'am here, and she's going to discuss a lot of insights which we need to know for clearing MRCP UK PACES communication scenarios. Welcome, ma'am.
Thank you so much, Dr. Moses, for your introduction. Thank you. I'm honored to be here.
Thank you, ma'am. Thank you so much. It's such a great pleasure to have you over here. And the very first thing I would like to ask you is, like, what make you choose MRCP UK or MRCP PACES? Like, many internal medicine residents now these days, they are choosing up, like, on that particular point of time, what was in your mind, how you wanted to do this examination?
So while I was doing MD, my post-graduation in MD General Medicine, my co-PGs wanted to do it. So this is the truth, actually. So they wanted to do it, and they encouraged me to take it. So the reason why they wanted to do it is they said that this exam would enhance our knowledge and focus on the important things, because we're learning many things. So it will help us focus on the important things and enhance our knowledge, and the approach to medicine as such would improve a lot if we take the exam. And this exam has very high standards. So this was the reason they gave for taking it, and they also encouraged me to take it. And this is how the journey started.
Absolutely. That's absolutely true, ma'am. This did enhance the clinical skills
Yeah,
of a lot of people.
yes.
Even I have seen professors of medicine, like, they're telling, like, this exam is just brushing up our clinical skills, especially bedside medicine skills. Absolutely, that's true. And can you just tell us about some of the memorable moments or some of the things you still remember about your MRCP UK PACES journey?
So when I started to prepare seriously for PACES, what I realized is this exam is more about practice. So I wanted to find a study partner. So I was randomly texting people on Telegram groups to just searching for a study partner. So I was really lucky. I found a really good study partner. So she texted me back and she said that she's willing to practice with me. And we started practicing like once a week or twice a week. And I thought I would apply for the exam in the coming diet, but because of COVID, my exam got postponed, and we were practicing like for around 10 to 11 months. We were practicing like once or twice a week, and it was very useful for me. So this was for consultation and communication. And after that, like towards the end of the exam, the last 2 months, I found two other study partners who had the exam on the exact same date that I had. So I was practicing almost every day. And also I got the help of a few good mentors in the last 2 to 3 months. And apart from that, for bedside, I was not able to find a study partner. So I used to just go to wards and time myself and see patients and discuss the findings there with the doctors who are available, anyone who's available at that time. So this is how it went. So if anyone who's preparing for PACES, just make sure that you practice regularly. It's good to find a good study partner. If not, at least practice with mentors, and make sure you see cases on a regular basis bedside. Time yourself and see for 5.5 minutes when you see, so that you would be able to do it in the exam like within 6 minutes and answer the examiner questions and offer your physical science. So this was my journey, and yes, it was a memorable experience.
Yeah, that's fantastic to know that. Like, even I remember during the COVID times, a lot of slots has been kept on canceling, and candidates absolutely had a great struggle to get through that. That was a really great thing to know, ma'am. And regarding the communication station, now it become a menace for everyone. Can you tell us, like, what a candidate needs to know about communication? Because many of us are, like, preparing offshore. Like, many of the candidates here, like, they don't have a proper UK exposure or UK experience, and this communication, the way they expect us to communicate with the surrogate and the patients, is slightly different from what is happening day-to-day basis on an international setting. Can you tell us, like, what candidate needs to know and how a candidate has to prepare for the communication station?
Oh, yes. So coming to the communication stations as such, there are. It's just that we have to be respectful to the patient and be empathetic to them. So that is what they expect in the beginning. And basically, you have to know that there are many different themes in communication. So you can get breaking bad news, you can get medical error, and you could also get complication of a procedure. So the main thing is the candidate has to be aware of the different themes that can come up repeatedly in PACES. So it is good to look at certain standard books. Like, for example, Rider has a list of themes that can come. It's not necessary to read each and every scenario, but what themes you can expect, you can just have an idea if you look at the topics there. And it's also very good to look at the scenarios from the website. So the theme can be explaining a disease, explaining a procedure, explaining starting a treatment, or counseling a patient. So there are many different themes. So you look at the scenarios in the website and also keep track of some recent communication scenarios so that it can help you to have an idea as to what exactly you will get in the exam. And mainly when you have an approach to each theme. So each theme have an approach, and just how you would go about. So the introduction and what exactly you would say in each different theme. And you have to have an idea of the ethical and legal issues surrounding each theme. So only then you will be able to approach the scenario properly. Only then the candidate will be able to approach the scenario carefully. So look at the different themes and look at the ethical and legal issues surrounding it, and see how you would start off and how you would end, and what you would have to say in the middle in each theme. And it's more about practice. So even though you know what to say, only if you keep doing it again and again, it will come as a flow in the exam. So try to practice either with a study partner, or even you can try saying those sentences out to yourself also. That might also help.
Absolutely, absolutely. That's true. And that's a very good, important advice, and every candidate should take that. It has to be, a list of scenarios. That absolutely, I do agree with that. That list of scenarios has to practice. That's true, ma'am. That's very true. Now, coming to one very important question, a very hot burning question that's happening over here. The recent PACES format, that is PACES 23, has made some changes, like from the communication station, which previously there was like, a 14-minute station, then some vivas, it almost like 20 minutes one, and now they had changed everything, and now there are two stations, no vivas, everybody's gonna mark down based on the performance, and with no interaction with the examiner ever. So what do you think are the differences? Is it some, are there any pros with this, are there any cons with that? Was it actually going to help the candidates? Can you just shed some light on that, ma'am? Yeah.
Okay, so the advantage of the current scenario is it is shorter. So the previous one was very long, which was unnecessarily long in the sense like 14 minutes. After that, 1 minute reflection time and 5 minutes examiner questions was not needed. The current format is shorter, so in that way it is better. But the main disadvantage of the current format is you're judged completely by the 10 minutes that you speak to the surrogate or to the patient, and judging is completely based on that. So when we say something, like for example in clinical judgment, when we say something that maybe we worded it differently or something, so the examiner perceives it differently, the candidates are being marked down in clinical judgment. So that is one thing. So it's better to be very exact and precise. And also, I mean, when you talk to the patient, I mean, you don't have to be give the exact treatment details. That is not necessary. But whatever you say, word it properly so that the understanding would be clear for everyone. So that is one disadvantage, because you cannot explain yourself. So whatever is done in the 10 minutes, and you're completely judged on what you do in those 10 minutes. You don't have any chance for explanation. So that is the only drawback. Apart from that, the current scenario is okay because it is shorter. 10 minutes is enough. 14 minutes was not necessary. So these are the main differences, like the time is reduced and examiner interaction is reduced. So make sure that whatever you say it properly, and make it clear so that everyone understands it in the same way.
Yeah, absolutely, that's true, ma'am. Because 14 minutes, some candidates just stuck up in the last previous format, and after 12 minutes, they just like a lot of candidates in the feedback, and even when they come and say, like, they will be like, I really don't know what to speak beyond this 12 minutes.
Yes,
They
it was
stuck up.
very long. It was very long. 14
Yeah.
minutes was long, but 10 minutes should be sufficient.
Yes, 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 ma'am. That's true. And rightly you pointed out that even in the current scenario, the other problem is there is no interaction with the examiner. So they perceive something and they are marking, and there, and what I have noted with the feedbacks is like, a lot of people have a discrepancies. One examiner has a completely different view. He just offers satisfactory. The other examiner has a completely different view and he is offering unsatisfactory for the same
Yes.
candidate. Those discrepancies are being noted nowadays. Yes.
Yes, yes, it happens. Yeah, I mean, I've been noticing it too.
Yes, exactly,
It
ma'am.
would be better if it can be standardized better that way, but yeah. So that's how it
Absolutely.
is anyway.
Yes, ma'am. And the next important question, the topic we are going to discuss today is like the palliative care and end of life care. And can you just shed some light as what is a palliative care and what is end of life care? And some candidates confuse between these two. Are they same? Are they different terms?
Okay, so palliative care and end of life care are similar in many aspects. There are a few differences. So, end of life care is just a type of palliative care that is given towards the end of life. So, that is the only main thing that you have to know. So, it is also a palliative care, but it's given towards the very end of life. So, that is what they mean by end of life care. So, first we'll discuss palliative care so that we'll have a good idea. And after that, we'll go to the specific aspects of end of life care. So, coming to palliative care, so palliative care is a type of care that is offered to a patient who has been diagnosed with an illness that cannot be cured and who has been diagnosed with a life-limiting illness that cannot be cured. So this is the main essence of palliative care. So it mainly aims to keep the patient as comfortable as possible and to relieve him of any distressing symptoms that he can have, like pain or shortness of breath or even insomnia for that matter, feeling sick, throwing up, or whatever it is. So whatever symptom they have, we are going to address the symptom and keep the patient as comfortable as possible, but we don't intend to cure the condition or give them a complete cure. So that is the main essence of palliative care. So the main thing you have to know about palliative care is it has to be holistic. So we look at the person, as a whole person, and we address not only the physical aspects, we also have to address the psychological aspects that might be bothering them, the psychological aspects, the social aspects, and if they need spiritual support, we can offer that also. So social aspects are also important because not only the patient is affected, the family members are also affected. So whatever care is needed for the family members or the carers, that can also be provided. So this is the main essence of palliative care. And end of life care is the type of palliative care that is given very much towards the end of life. So usually they say like 1 year. I mean, when a person has less than 12 months or 1 year to live, it is called end of life care. But it's not always like that. It can be the last few days, it can be the last few weeks, it can be the last few months. And sometimes a person who has been put on end of life care can live for more than a year also. They can live for 1 to 2 years also. So that is also possible because it's very difficult to predict when the person is going to die. So, but that's end of life care. The main difference is being palliative care, they can continue giving the other therapies that are, the therapies that they've been receiving for the disease. For example, if they're getting any treatment for the disease, they can continue, they would be continuing it. They may continue it in palliative care. So that is one thing. Apart from that, palliative care can also offer palliative procedures. So if the patient has any, for example, they can do an ERCP with stenting, or they can go for other procedures. But usually in end of life care, everything is avoided. End of life care is only aimed at keeping them comfortable. Only symptom relief is provided in end of life care. And palliative care, along with that, they can also offer some palliative procedures. So this would be the differences. And palliative care is the care that is given immediately after diagnosing. End of life care is given when we are not expecting the patient to live for long, maybe a few months, that's all. So that is what we expect. And I mean, those type of patients are put in end of life care. So palliative care and end of life care can be offered anywhere. So it can be offered in the community, in the house itself, in the comfort of their house, it can be offered. So it can be liaised with the GP and community nurses who can go to their house and offer palliative care. And it can also be offered in care homes and nursing homes or care homes. And it can also be offered in the hospital. Apart from that, hospice care is there. So hospice care can be provided at home. And so these are, it can be offered anywhere, like home or care homes or hospitals. And the patient can also, we can talk with the patient, find out their interests and what they would like, what they would not like, how they would like to be treated. All this can be spoken. So look at the patient as a whole and address them as a whole. So this is the main essence, and providing them support for everything. So that is for all distressing symptoms and even psychological symptoms that they have, like I mean the psychological aspects that they have, that should also be addressed.
Fantastic, fantastic, ma'am. That's absolutely very eye-opening thing. Like, because we were also like thinking about what is this palliative care and end of life care when we were preparing, like, there's a lot of confusion and a lot of, overlaps between this term. Now you made it absolutely clear, and thank you so much. And then the next thing we need to discuss here is like, how a candidate should approach a palliative care or an end of life scenario, because wrong approach leads to like derailing and some pauses, some candidates like stuck in between. So how a candidate should structure an approach whenever they are facing a palliative care scenario or an end-of-life care scenario?
So mainly, many scenarios of palliative care are clubbed with breaking bad news. So that is one thing. So if it is that way, just break the bad news first in the usual pattern. So establish the patient's pre-existing ideas, knowledge, and see if they have any thoughts about the disease, and then give the warning shot and break the bad news, and then tell that you can then tell that we're going to formulate a management plan for them. I mean, you need not use that word. You can just say that we are aiming to support you as much as possible. We have decided to put you on a type of care that we call as palliative care. Don't worry about the term. It is just a supportive care. It is supportive care that is provided to you. And it's because the illness that you're having now cannot be cured, but we will be providing you all support that is necessary to keep you as comfortable as possible. So, and after that, mainly see what concerns the patients have and see what expectations they have. So check their concerns and expectations from time to time. And that is very important to address their concerns and expectations, because what we are having in mind might not be what the patient has in mind. So that is very important in any scenario, not only in this palliative care, end-of-life care scenario, in any scenario for that matter. And check whether the patient has any dependence on them, because there are many things. It's not only about treating the patient. He might have some dependence. He might be worried about them and the support that he has available at home. So he might not have any support at home. So we might need to offer him extra support in that way. So these are other aspects you have to check. And yeah, so explain what palliative care is. For if you have to break the bad news, break the bad news. And after that, explain what palliative care, end-of-life care, whatever has been given to you in the scenario, explain it. And then address any concerns that you have along the way and check for any supports, dependence. And also you can ask whether they have any advanced directives, or make them, I mean, you can ask them to think about writing down any wishes as to how they would want to be treated in future. And also appointing someone to take healthcare decisions on their behalf. That is called the lasting power of attorney. So all these can be discussed with the patient once they come to terms with the diagnosis. And before that, check their concerns, check their understanding, and explain clearly what palliative care involves, and offer them a lot of support and empathy.
Absolutely true, ma'am. That's absolutely true. That's very valuable points here when it comes to approaching that. And many candidates make a mistake of not asking the social history and what is the social situation and offering
Yes.
them.
So main social history here should be like what support they have available at home. So that would be more important than digging into their other personal habits, because that's and the dependence they have available. So that would be a very important, and job and impact. So what they're doing and how it's going to affect them. So all that would be very important social history that you have to ask in palliative care scenarios.
Absolutely. Absolutely, ma'am. Absolutely. I cannot agree more with this. This is absolutely very important thing. And one more thing, like, what do you think are the common mistakes candidates make? You have guided multitude of candidates. You'd be definitely knowing what common mistakes candidates do when it comes to approaching a palliative care or an end-of-life care scenario.
So mainly, most of the palliative care scenarios are clubbed with breaking bad news. So one common scenario that common mistake that candidates do is they rush into palliative care without breaking the bad news adequately, because many scenarios have multiple tasks. So when there are multiple tasks, candidates get caught up with finishing it. So don't make that mistake. So if it's breaking bad news, we have to be gentle. So offer the bad news and wait for the patient to respond, and then we can go to palliative care. This is because many palliative care and bad news are clubbed together. That is why I'm saying this. So offer the news and give a break, and then don't give a break. So give the one. Let the patient respond. So let the patient respond, look into the eyes, and then you can talk about palliative care. That is one mistake that is made, and not listening to the patient properly. So many times we are so caught up in talking, we don't listen to what they say. That is a very, very common mistake. So listen to what they say, address what they say. It is more about addressing the patient's feelings rather than us completing our task. So listening properly and addressing their, whatever troubles they're having in mind is very important. And evading concerns. So when they have a concern, completely evading it and going on to finish the sentence that we are saying. It's okay to finish the sentence. If you're in the middle of the sentence, it's okay. But after you finish the sentence, at least acknowledge the concern. If you think it's too early for the concern and the explanation for the concern will come later, you can at least acknowledge. You can say, I appreciate your concern. I would definitely be addressing it. But before that, can I say this? So you can do that, or it's better to address the concern then and there. So not addressing the concern, evading the concern, not listening properly, rushing into it, all these are common mistakes made. And another very common mistake is not getting the scenario properly. So you have to read the scenario carefully. Just a few words would be very important. Whether the patient has capacity or not would be very important if you're talking to the relative, or whether the patient has, whether the disease, if you're planning to do a procedure, whether it's going to be done definitely or it's to be decided in the future. So certain things are very important. So read the scenario very carefully and don't make the mistake of getting the scenario itself wrong. So these are some common mistakes that are made generally in all scenarios, and also in the palliative care scenario. And awful lot of empathy. Don't repeatedly say sorry, sorry, sorry. So that also many examiners don't like. So once is enough. Say, I'm really sorry for what you're going through. If you want to say, you can word it differently. This must be a very difficult time for you. We'll see what support we can offer for you. So once or twice you can say, I'm sorry for what you're going through, but don't repeatedly use the same word. It might not be that comforting for the patient. So once or twice, and then word it in a different way. Offer empathy in many different ways.
Absolutely true, ma'am. Absolutely, that's true. And I've noted this thing when particularly evading a concern is very, very important. I've seen some candidates failing in concerns because that is only in 4 stations. Like they can make it up either in the clinical consultation or in the clinical communication. And many candidates, what I have noted personally, when I was a part of some PACES examination, is like these candidates come there and they just even after the last 2 minutes warning, they'll keep examining, or they will keep on talking something else, where surrogates like us are given at least 3 to 4 concerns to ask the patient, ask the candidates. They wouldn't give any chance for that, and by the time
Yes.
the bell will ring, and they'll be out. And that's with that, I would like to ask, like, what do you think are the common concerns that are asked in this type of scenarios, ma'am?
So one very common concern is, how long do I have remaining? When will I die? This is a very common concern in palliative care and end of life care, because they've given a diagnosis of a life limiting illness. So it's very difficult to say. It's very difficult to predict when a person is going to die. So you can be honest about it. You can say it's very difficult to predict because each person's disease progresses differently. So we have to keep you under monitoring and follow ups. Only then we might. It's very difficult to predict exactly when when you're going to die. But then you can offer them a rough idea, because they will be very anxious. So if something is given in the scenario like he won't live for more than a few days or months, you can mention it. So you can mention. Otherwise, you can use your own judgment. You can say that's very difficult to say, but looking at what you have, we are talking about maybe a few months here, or a few weeks here, or maybe 1 or 2 years here. So depending upon what your judgment is, you can offer in the form of maybe a few weeks or months or few months. You can just a few days or whatever. So you can use it that way. But don't give the exact number. Don't say that you might have 1 week remaining, 2 week remaining. Don't use exact numbers, because it's very difficult to predict. No one would know. You can just roughly say a few weeks or few months, depending upon the scenario that you have in hand. And apart from that, that's a very common concern. Apart from that, another common concern is, where can I get the palliative care? So for that, we already discussed it can be available in the hospital, the community care homes. So just what we discussed earlier, you can say we have hospice care. So whatever is available, you can tell that. Another common concern, especially in end of life scenarios, when you're talking to the relative of the patient, is, can I take him home? So anyway, I'm not going to cure him. Can I take him home? So of course they can take them home. You can say, yes, you can take him home. I'll discuss with my team prior to that, and I'll make arrangements in the community for him. I'll talk to we'll contact the GP and community nurses and see what help can be offered for him at home, and you can take him home. You can also ask the support that would be available for him at home. If no support would be available, we can offer that also. So mainly, if they want to take, they can take them home. And before that, you can also explore what wishes the patient had, because some patients would not want to die in the hospital. So you can also explore that. So if they had any specific wishes. And another very, very common concern in end of life care is feeding. So they will ask, my mother is not eating at all. So if the patient is conscious, they will ask that. If the patient is unconscious, they will ask, how are you going to feed him? My mother is not conscious. So this is a very, very common concern that is asked in end of life care, especially even in palliative care. So in end of life care, or palliative care for that matter, like especially in end of life care, towards the end of life, the patient's nutritional requirements would go down. So their fluid intake and food intake will reduce accordingly. So you have to explain that in a very empathetic manner to the relative. So if the daughter asks, my mother is not eating, can say that she won't need, like, because she's approaching the end of life, the amount of food or fluid that she needs would be less compared to us. So that is why she's not eating that much. So you can offer her food and water from time to time. So we have to offer them. So that is the main thing. Offer them food and water from time to time, but they would eat what they want to eat. We should not force them. So this is the main concept when it comes to a patient who's conscious in end of life. But if the patient is not conscious, they would ask about tube feeding, like how are you going to feed, and about tube feeding. So mostly in end of life care, they don't go for tube feeding or other distressing forms of feeding. We do usually avoid it. So you can just say that the same thing, their food requirements can go down and the amount of fluid they need also would go down, but we will keep them under monitoring. So we keep them under monitoring, and if we feel that they would need, so the if hydration in end of life is a little a tricky and controversial thing. They keep monitoring the patient from time to time, and if needed, if they feel that the patient would be in distress, then they might give them some fluids, either through the intravenous or subcutaneous. And very rarely they can go for ice tube. It's very rare, but it is based on assessing the patient from time to time. So they ask about an unconscious patient, you can just say that they won't need that much of food or fluid that we need, but we would be monitoring them from time to time. And if we feel there is a need, that if we feel that they are in distress, or if we feel that there is a need, then we might give them some fluids. So you can put it that way. But basically, in end of life care, or in end of life, the patient's nutritional requirements would be down, and if they're conscious, they won't eat that much. So these are the common concerns, like taking them home when they would die, and where they can get the palliative care. And yeah, so these are the common concerns.
Absolutely. That's a very important thing. That's a concerns, like how to address the concerns and what are the common concerns. I believe it will be absolutely benefit all the candidates who are listening to our podcast. And the final question is like the ethical and legal issues and the previous communication format, like typically the examiners stop by and ask like, can you tell me what are the ethical and legal issues involved in this? Nicely they will ask and candidates talk. Now we have to make sure the examiner sees and understand that we are inculcating these things in our convocations. So how to do that, and what are the common ethical and legal issues involved in this palliative care and as well as the end of life care, ma'am?
Okay, so ethical issues are almost common to all scenarios, which will also apply to palliative care. So ethical issues would be autonomy, beneficence, non-maleficence, and justice. So the same thing here. So in autonomy, in palliative care, you have to take into account what the patient actually needs and what the patient wants and what the patient does not want. That is why we have to discuss everything with the patient and respect their wishes. Especially in end-of-life care, we are not going to give them anything that is going to cause any distress to them. So you have to speak to the patient and understand what they feel about it. And beneficence and non-maleficence are very, very important aspects of palliative care, because we should not offer therapies that are going to cause any distress. So whatever we are going to give only to benefit the patient. We won't give any treatments, like we are not going to give any strong chemotherapy, anything which can cause them distress in their last days of life. So that is about beneficence and non-maleficence. And of course, justice is treating the patient, all patients equal, regardless of the race or gender or any other differences, like any other beliefs that they might have. So this is about the ethical issues. And coming to legal issues, the capacity of the patient and confidentiality of the patient are legal issues that surround almost all scenarios. So capacity, if the patient has capacity, the patient would be taking the decision. For example, if you're talking to the daughter and the father has capacity, you have to know that whatever the daughter says, the father's decision is going to be final. So that is one thing. And confidentiality, if you're going to talk to the patient's relative, you have to make sure that you got the patient's permission. So you can start the conversation by saying that I have your dad's permission to talk to you, if you're talking to a relative of a conscious patient. And if the patient, so this is capacity and confidentiality. Apart from that, two important legal issues surrounding palliative care and end-of-life care is advanced directive and lasting power of attorney. So you have to ask, so if you're talking to a patient who's conscious, you can ask them to think about what they can write down. I mean, whether they would like to write down any legal wishes as to how they want to be treated in the last days. And if you're talking to the relative of an unconscious patient, you have to check whether the patient has any advanced directives or lasting power of attorney. And lasting power of attorney is the person who's going to take healthcare decisions on their behalf, a person who's legally appointed to take. So when a patient is not conscious, check whether he has any advanced directives or lasting power of attorney. If the patient is conscious and if he's approaching end of life, you can ask him to consider writing down advanced directives or lasting power of attorney. So these are the main legal issues that would surround the capacity, confidentiality, advanced directive, lasting power of attorney in any palliative care or end of life care scenario.
Absolutely, absolutely. You covered absolutely everything, ma'am. That's really fantastic. And we have just have a huge glimpse of like, end of life care and palliative care and how to approach the scenario. So, before we just wind up and conclude, can I just ask you, ma'am, like, what are the final concluding things you want to tell a candidate preparing for PACES and candidates who are going to face this palliative or end of life care scenario in their PACES exams?
Okay, so read the scenario carefully, break the news gently because many times it is clubbed. If they already know, then you can skip that part and then explain clearly and concisely what palliative care is about. You can say that we are going to offer you something called palliative care and tell that it is a supportive care and whatever that we discussed prior, like managing the symptoms and everything, and then ask for any concerns that they might have and also address any concerns that they have and be very empathetic and include the patient in the conversation and always try to explore what the patient might think. So explain palliative care properly, explain where it can be provided, where all you can provide palliative care, and tell about the other. Ask about dependence, social support, ask about advanced directives lasting power of attorney. Mostly, if the patient is too much in distress, we can't go for advanced directive lasting power of attorney. Try to make sure that the patient has come to terms with the diagnosis, and then you can discuss advanced directive lasting power of attorney. Ask the patient to think about advanced directive lasting power of attorney. And yeah, and then when you concluded, just offer again some empathy. This must be a very difficult time for you. If you need any support from our side, you can always contact us. This is our contact number. You can get back to us anytime that you want. And yeah, so this is how we can conclude.
Absolutely, absolutely, ma'am. Absolutely. We have covered everything for this, and we'll have more podcasts with ma'am in the upcoming days regarding all the communication scenarios. And I hope you all enjoy the podcast, and it would be definitely fruitful for you in your PACES examination. Thank you, ma'am. Thank you so much for being a part of this podcast, and thank you so much again. And we would love to have more and more podcasts with you in the upcoming future. And thank you so much, everyone, for listening to this. And thank you from PACES Diaries team. Thank you.
Thank you, Dr. Moses. Thank you for giving me the opportunity. Thank you.
Thank you.